I thought we'd go ahead and get started. We're at Duke time, 12 o'clock. So I just want to introduce Dr. Vern Jewell, who has graciously come to teach us. Dr. Jewell is a graduate of the University of Illinois College of Medicine. He completed his neurology residency and his neuromuscular fellowship training at Duke. He was appointed to the neurology faculty at the University of Virginia in 1994, and he returned to Duke in 2004 to join the Division of Neurology and to direct the Neuromuscular Medicine Fellowship Program. Dr. Jewell is board certified in neurology, clinical neurophysiology, and in neuromuscular medicine by the American Board of Psychiatry and Neurology, and in electrodiagnostic medicine by the American Board of Electrodiagnostic Medicine. Dr. Jewell has previously served as chair of the Consortium of Neurology Clerkship Directors of the American Academy of Neurology, and he is currently chair of the Graduate Medical Education Committee of the American Association of Neuromuscular and Electrodiagnostic Medicine. He has directed the workshop in Advanced Techniques in Electromyography and Neuromuscular Disease at the last 4 annual meetings of the American Academy of Neurology. His areas of academic interest include neuromuscular disorders, particularly diseases of the neuromuscular junction, and neurological education. So please join me in welcoming Dr. Jewell.
Very good. Lots of prepositions in there. Okay. Well, I guess my charge today is to try to have everybody come out and understand what the term neuromuscular disorders means and the diseases encompassed by that term. And I think in the process of doing that, we'll be able to highlight the diseases that we've had a lot of therapeutic success with, in large part due to some good clinical trials, and some diseases that we've got some work remaining to do. And you know, some of your group will probably be involved in the trials in the future, some in the very near future, that will address some of these diseases and hopefully give us better treatments. Okay, so what are neuromuscular disorders? They are not necessarily disorders of the central nervous system. Many people come to me and say, "Oh, well, you're one of those people that treats those, alphabet soup diseases, MS, ALS, MG." Well, multiple sclerosis is not a neuromuscular disorder, and I'll explain why that's the case. I'm going to go through, I'm going to try to explain this using anatomy, so this will be a flashback to your undergrad or graduate school anatomy courses, so please stop me if something isn't very clear. I want to talk a little bit, not in great technical detail, but a little bit about the diagnostic tools that we have available for neuromuscular disorders, and talk about their benefits and their limitations. Do a survey of selected neuromuscular diseases, some of our successes and some of our trials to come, and then we'll conclude. So neuromuscular disorders may involve the peripheral nerve, which came from plexi, which came from nerve roots. And there are motor nerves, there are sensory nerves, and there are autonomic nerves that in many cases traverse the same mixed nerve segments. The neuromuscular junction, both the pre- and the postsynaptic components, and skeletal muscle. So I'll start out with, let's see, anatomy here. And here is a cross-section of the spinal cord. And this is the dorsal or posterior portion, and here's the anterior or ventral portion. And let's start out with where motor nerves come from. So this is the anterior horn of the spinal cord, and all the cell bodies of the lower motor neurons reside here. And all of these cells send a projection down through the motor root, where the motor and sensory roots join at this point to form a spinal nerve or mixed nerve root. And then the nerve roots somewhere in here become organized into individual peripheral nerves through a network of nerves or plexus. And then the peripheral nerve approaches a muscle and then ramifies or divides many, many, many times to innervate individual muscle fibers at a special place called the neuromuscular junction. And except in the extraocular muscles, each muscle fiber has one neuromuscular junction. So, however, one motor nerve innervates many, many muscle fibers. So in the gastrocnemius muscle in one's calf, the ratio of motor nerves to muscle fibers is about 1 to 2,000. So there's a tremendous amplification effect. Conversely, if that motor nerve is diseased, a tremendous amount of weakness can potentially result. On the other hand, our extraocular muscles are designed for exquisitely precise movements, and the ratio is about 1 motor nerve to 14 muscle fibers, so different muscles performing different functions. The sensory part of the peripheral nervous system is composed of this dorsal root ganglion cell and its distal projections that come from various sensory receptors in the periphery, in the joints, in the muscle for muscle stretch, under the skin for pain and temperature and light touch. And then there is a proximal projection from this dorsal root ganglion cell that is modality specific. So for vibratory, light touch sensation and joint position sensation, the fibers ascend ipsilaterally ultimately to the thalamus in the so-called posterior columns, whereas for pain and temperature, the fibers ascend a couple levels, cross to the other side, and then ascend in the lateral spinothalamic tract. Hopefully this isn't a very bad flashback to grad school here. All right. Good. And this is another view. This is, I know you can't read this, and I don't expect you to, but this is the brachial plexus. And the brachial plexus is derived from nerve roots from the C5, 6, 7, 8, and T1 levels. And the plexus is where all of these nerve roots become organized into individual peripheral nerves. Okay, the brachial plexus, because of its location in the proximal arm, can be subject to injury, and we'll talk about circumstances when that occurs in a little bit. All right, good. All right, so now let's go down to the microanatomy of the peripheral nerve, because this becomes relevant in some of the diseases we'll talk about. So this is a section of a whole peripheral nerve here, and the peripheral nerve is covered by an epineurium. And then we have individual nerve fascicles within the nerve that have that in addition to having nerve fibers, have lymphatics, blood vessels, and other support tissues. Let's talk a little bit about these nerve fibers. There are different types of nerve fibers. There are heavily myelinated fibers that carry, in the case of motor nerves, information to the muscles, and in the case of sensory nerves, stretch information back into the central nervous system, namely to the cerebellum, so movements can be modulated very rapidly and very precisely. Now these unmyelinated fibers are very important, and these are mainly specific to sensory and autonomic nerves. Okay, they conduct signal much more slowly because they aren't wrapped in myelin, and they have a different structure of internodes. But these particular so-called unmyelinated nerves transmit information about autonomic function to and from the nervous system and sensory function, namely for pain and temperature. On this side of the panel, you can see a blow-up of this myelinated fiber, and we have our Schwann cell nucleus here, and the Schwann cell has wrapped many, 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 many times around the peripheral nerve and formed this compacted myelin. This is a very important place between the myelin. This is the node of Ranvier. Okay, this is where all of the sodium channels are clustered so-called saltatory conduction of nerve impulses. So this is a very, very important site. All right, let's go on. I would also, if there are any questions, instead of holding them to the end, just raise your hand and I'll try to address them because we're going to cover a pretty broad spectrum. Yeah, go ahead.
So I guess my first impression, and you did flash me back to, is you've got this like intense superhighway out there, your original, nerve fiber bundles or whatever. Can you just say the brain is what's directing all this activity, correct? Through the spinal cord?
Correct. So the lower motor neuron that originates in the anterior horn cell is getting information from the so-called upper motor neuron or corticospinal fibers. And I've deliberately not talked about those because those are conceived of as residing in the central nervous system. These distinctions we make between the central and peripheral nervous system are really very arbitrary, and these are all functionally integrated things. I'll go back here. This dorsal root ganglia cell has a projection that goes out distally into the extremity. It also, in the case of vibration and proprioceptive function, has a projection that goes all the way up to the level of the medulla. These are incredibly long cells. So this sort of artificial distinction that a lot of us make between the central and peripheral nervous systems is again a very semantic one, and there is functional integration. That's good, really good question. All right. Okay. I'll talk a little about the neuromuscular junction now. There's a lot of biology that happens at the neuromuscular junction, and because of that, there are a lot of potential things that can go wrong there. This is a nice photo here of a motor nerve fiber and its ramifications into very, very small fibers. And you can see the neuromuscular junction here on these individual muscle fibers. So this gives you a nice visual of how this looks. Now, the one thing I should comment on is that for an individual anterior horn cell or motor nerve, the muscle fibers are spread out. They're not all clustered together in a contiguous way. And I'm sorry I didn't have a slide to demonstrate that. This is an electron micrograph of the neuromuscular junction, and let me orient you here. So this is the terminal motor neuron. Okay, so this is one of these, and these small rounded structures are vesicles of acetylcholine that are waiting to be released. Our synaptic cleft is this small space in here. And this is our postsynaptic muscle membrane. So we have motor nerve here and muscle here. And what has to happen at the neuromuscular junction is we have to release these. There has to be diffusion. Those acetylcholine molecules need to dock with specialized receptors that are on the tips of these villi, okay, that are very close here. The highest concentrations of receptors are right up here. And then the acetylcholine is deactivated by an enzyme called acetylcholinesterase that lies right down here in the clefts. Okay. All right.
Dr. Jewell,
Uh-huh.
what kind of magnification are you talking about?
Oh, for this?
For either one.
Wow.
Ballpark, I mean.
Probably, wow, I would be guessing 5,000. That's an uneducated guess.
Joining conference.
Since I'm not a
Brenda
pathologist.
Shaw.
All right. So this is a photo I stole from the Steve Arnon's article in JAMA on bioterrorism and botulism. But this is one of the nicest, I think, cartoons of neuromuscular transmission I've seen. The reason I'm showing this is the mechanism by which these small vesicles actually move to and dock with the presynaptic membrane and release their contents is very complicated. It involves these so-called snare proteins, and it is these proteins that are the site of attack in the disease botulism. So there are proteins that are associated with the synaptic vesicles themselves, and there are some proteins that are associated with the plasma membrane here. And each serotype of botulinum toxin has a specific protein and site on that protein that is cleaved. So there's exquisite specificity for various sites on these proteins for in botulism for prevention of release of acetylcholine. And then here you see a nice drawing of the acetylcholine receptors that act as sodium channels. So let's kind of walk through the steps of the process just so you all are clear. So the nerve action potential comes way up from that anterior horn cell, and it zips down here to the nerve terminal. The voltage-gated calcium channels then open, and the calcium influx sets off this cascade of events where the synaptic vesicles are drawn down to the plasma membrane and release acetylcholine into the synaptic cleft. Acetylcholine binds to these receptors, and sodium enters the muscle fiber at the postsynaptic membrane. And if there's a great enough depolarization of the postsynaptic membrane, an end plate potential is generated. The potential is propagated bidirectionally down the muscle fiber, setting off a series of events called excitation-contraction coupling, in which actin and myosin interact and the muscle contracts. Okay, and here's the skeletal muscle slide to follow up on that. So here is a cross-section of a muscle fiber, and the outside of the muscle fiber is called the sarcolemma. These structures inside, the filaments, are composed of actin and myosin that interact with each other, and they physically cause the muscle contraction. I would point out a very important structure, how these two things are connected. How are the contractile parts of the muscle anchored to the sarcolemma? And these structures are called costomeres. Okay, this is a relatively new concept in muscle, that there need to be these anchoring structures. And this will be really important, as I'll get to here in a moment. Okay, so we'll switch gears here a bit, and I'll talk about diagnostic tools in neuromuscular disease. So the most important tool is the clinician who's actually speaking with the patient and doing the examination and raising hypotheses about where the problem in the nervous system, or in this case the neuromuscular system, is located. Go ahead.
So I'm just trying to, again, just drill down just a little bit. So what you're talking about is you're talking about electrical impulses and biochemical interactions working together to make that muscle move. Is that?
That's right. So the neuromuscular junction is not an electrical one. It is a chemical junction. So the docking of acetylcholine with the acetylcholine receptors causes an electrical event. It causes the influx of calcium that sets off depolarization of the muscle membrane, and then that incites another chemical event where actin and myosin interact with each other to cause contraction of the muscle fiber. So there's, I'd not conceived of it that way, but there are some it's not all electrical.
Right,
Nor is it all
exactly.
chemical. So.
But this is actually very interesting to me and something I can never wrap my head around. I guess basically what it is it's chemical reactions, as you said, and then some of those will then stimulate electrical activity.
Correct. So the propagation, the propagation of impulses from one part of the nervous system to another is electrical, but where the connections occur are chemical. So the synapses are chemical. I do believe birds have an electrical synapse for a special membrane that closes over the eye called the nictitating membrane. But we have chemical synapses. Okay.
Just a minute.
We got people on the stream.
And I mean, at this level, isn't really one of the questions is understanding what does electrical mean, and isn't it really kind of charged ion?
The movement, yes, the
So,
movement of ions, and for me to segregate that into electrical is artificial.
but
it
I
is
think
chemical.
it's kind of because sometimes electrical we think of putting a plug in the wall and,
Right.
and electrical energy, but really
Right.
at a chemical level, it's positive and negative charges that are
Yes.
shifting and moving,
Yeah.
and which causes activity.
I like that better. So the movement of charge, that's probably a much better way to think of that. Okay. All right. So diagnostic tools. So the old tool is the clinical examination, and that's still the first place to start with. And there are some diseases that have very specific findings. The fluctuating and fatigable eyelid weakness in Myasthenia Gravis. I don't know of any other disease other than its cousin, Lambert-Eaton myasthenic syndrome, that can produce that phenomena. On the other hand, there are diseases with very nonspecific findings. Limb-girdle muscular dystrophies, of which there are nearly 20, probably more than that, will all present with weakness in a limb-girdle pattern, and there aren't too many specific findings on the clinical exam to tease those apart. Electrodiagnostic studies, or EMG and nerve conduction studies, can tell us a lot about peripheral nerve, junction, and muscle in terms of function. So we see characteristic findings in certain disorders. For example, in the Guillain-Barré syndrome, we can see evidence of acquired multifocal demyelination, but Guillain-Barré syndrome is not the only disease that can cause that finding. So while electrodiagnostic studies are useful, in particular because we can do them rapidly and gain additional insight into disease and what the location of disease causing, for example, weakness is, they don't always yield very specific findings. Muscle histopathology can be very useful, but it's invasive. So either nerve or muscle histopathology is important, but it's invasive. There can be sampling error. We have patients with mitochondrial muscle disease that our sample of muscle yields no pathology or no specific pathology for mitochondrial muscle disease, which is very vexing because we've had to talk a patient into a biopsy and we have negative or nonspecific findings. The quantity of material can also be a problem to be studied because we're constrained by how much material we get out. And muscle biopsies especially in end-stage muscle diseases, don't always yield very many muscle fibers. So this is a problem. And histopathology also may not yield unique findings. For example, in limb-girdle muscular dystrophies, unless you have an immunohistochemical stain for a particular protein available, many limb-girdle dystrophies will look all the same under the microscope, unless you have the insight to be using that particular immunohistochemical stain. So immunology can yield very specific findings. For example, acetylcholine receptor binding antibodies in autoimmune acquired myasthenia gravis are highly specific, although they aren't always very sensitive for the disease. And there are some immune-mediated disorders that we're still looking for antibodies, namely the Guillain-Barré syndrome. For many years we've been hunting for either a particular antibody or set of antibodies in this autoimmune disorder, and we've yet to find them. So we have diagnostic criteria for the Guillain-Barré syndrome, but we don't have a specific biological antibody marker. So that is a problem. Bioassays. We still diagnose botulism, or we still confirm the diagnosis of botulism with the mouse bioassay, which requires that you have a mouse colony that you immunize against all the serotypes of botulinum toxin, and you take serum or food extracts or stool extracts, and you immunize several colonies of mice, and the ones that die had that particular serotype of botulism. This is very resource intensive, and it's slow. It's very slow. I'll talk about that a little more later, but that's a big area for development. Okay, molecular genetic studies. These are very specific. These have been very important in diseases like Duchenne muscular dystrophy because there are different ways, there are different molecular lesions of the dystrophin that can cause Duchenne muscular dystrophy. The problem is that there's several problems. One problem is if there's a novel mutation that's never been reported to cause disease, what does that mean? We could do a family study, but you know, if the family's not available for a study, that's problematic. What if we have a limb-girdle muscular dystrophy, no family history, and no specific findings other than weakness in an appropriate pattern and findings that tell us we have a muscle disease that isn't autoimmune? Well, we could run the whole panel of laboratory studies. Those panels run almost $5,000 today. The panel for all the available mutations that cause Charcot-Marie-Tooth disease, hereditary motor and sensory neuropathy, is almost $6,000. And yet our high complexity initial office appointments are a little over $200. So, you know, these are very resource intensive. Okay, go ahead.
Oh.
It's coming on.
So with the current level of ability to do testing, does knowing the particular issue actually help you in treating? Like, for instance, you've spent $5,000, $6,000 on a panel. Whether you know for sure, does it make a difference clinically?
Excellent question. and the answer is sometimes it does and sometimes it doesn't. And I just came from the muscular dystrophy clinic, and I'll give you an example of something we encountered today. So in Duchenne muscular dystrophy, and I'll talk about this in a moment, there is one of the mutations causing a premature stop codon that we've got a clinical trial of an agent that allows read-through of that. So if you have Duchenne dystrophy, sequencing your dystrophin gene for where's the mutation is probably something that's really important. And you know, as somebody that runs one of those clinics, I want to know everybody's mutation because that's going to determine if they're eligible for a clinical trial and which one. On the other hand, for a rare autosomal recessive limb-girdle dystrophy, or even for fascioscapulohumeral muscular dystrophy, which is the second most common autosomal dominant adult onset dystrophy, we know the location of the gene abnormality, but we don't know what the abnormal gene product is. We are years away from any kind of treatment for that. So in those instances, I'm not very anxious to get to do the molecular studies because we don't have anything to offer just yet. So it's very dependent on where we at in terms of offering treatment and how curious the patient is and what sort of resources they have to pursue that curiosity. So good question though. Imaging. So any of you who have had MRI studies know that these are very pricey also. And at least at this point, except for showing different distributions of nonspecific myopathic findings, the MR doesn't give us any unique information. In the person, for example, with a muscle disorder that has a predilection for anterior thigh muscles, we can show that there are myopathic changes in anterior thigh muscles. But you know, that's about how much value we get out of several $1,000s of MR. One of my colleagues, Lisa Hobson-Webb, is working on a study of ultrasound, quantitative ultrasound in muscle. And this, I'm very biased, but I think this sort of activity has a lot of promise because you can get information in real time. It is very inexpensive information to get, but we still have some work to do. We don't have a way just yet to quantify ultrasound signal so that we can compare diseased muscle from patient A to patient B or even in patient A over time. And so that's one of the areas for investigation in terms of studies that we have. All right, now I'm going to survey some diseases, and hopefully now that we've gone over some of the anatomy, you can start to integrate diseases that you all have heard about and where they kind of fit in the neuromuscular world. So I'll start out with focal peripheral neuropathies. All right, so these are usually due to compression or trauma. So far and away, the most common one of these is the carpal tunnel syndrome. Statistically, probably a quarter of you have had this at one time or another. This is just entrapment of the median nerve below the transverse carpal ligament. There are conditions that increase one's risk for this, such as hypothyroidism or pregnancy, and there are activities such as repetitive wrist flexion and extension that also increase your risk for this. There are some other compressive neuropathies I'm not going to mention. Ulnar neuropathy at the elbow and perineal neuropathy at the fibular head are the three most common compressive neuropathies. So in terms of public health, this is not an insignificant problem. A lot of people seeing physicians about this. Okay, obstetric brachial plexopathies. So this is a baby with Erb's palsy, and Erb's palsy involves a stretch of the upper trunk of the brachial plexus, usually due to something called shoulder dystocia, where the child is large for the birth canal and the shoulder becomes fixed under the symphysis pubis, and the angle between the head and the shoulder is increased, acting to stretch the upper trunk of the brachial plexus. So this is an issue in the pediatric world. I would also say that we see brachial plexopathies due to the same mechanism in football players as they throw blocks and increase that angle between the neck and the shoulder, and the instance we see it most frequently these days are motor vehicle accidents, particularly with unrestrained occupants. Radiculopathies owing to spine disease. This is a huge public health problem. This composes a large fraction of our practice. So either disc herniation or the formation of osteophytes that encroach on nerve roots or into the spinal canal on the spinal cord. So in terms of public health, this is pretty big, and closed and penetrating trauma is also fairly common. Generalized peripheral neuropathy due to systemic diseases is our next topic, and diabetic polyneuropathy is far and away in the first world the most common cause of peripheral neuropathy, and these are just the ulcers on the plantar surface of the foot of a patient with diabetic polyneuropathy. This is a major issue, and although there have been some trials to try to treat pain in diabetic polyneuropathy, I'm not aware of any that have actually tried to improve nerve function. So we do have effective treatments for neuropathic pain, but we just don't have neuroprotective agents for the peripheral nerves in this disorder. I suspect that there's a lot of capital that's gone into that since it's such a common issue. In the third world, vitamin deficiencies are a larger issue. Toxins and medications are a significant source of polyneuropathy, as well as HIV-related polyneuropathy. In our practice here and in tertiary medical centers in the U.S., idiopathic neuropathy, that is, there's no known underlying medical disorder, is about half of our population. And then finally, secondary immune-mediated peripheral neuropathies due to lupus, rheumatoid arthritis, myeloma, other paraproteinemias are a significant portion of our practice, but not a huge public health problem in general. Actually, a very large part of our practice is autoimmune neuropathy. So I'm going to talk about primary generalized neuropathies now. So the Guillain-Barré syndrome and its cousin, chronic inflammatory demyelinating polyradicular neuropathy, or CIDP, and variants of CIDP are a big part of our practice. And with both of these disorders, the immune system attacks peripheral myelin epitopes. And in some of these diseases, we've found antibodies that are decent markers for disease, although the robust quality of these is somewhat dubious. But some of these patients with CIDP do have ganglioside antibodies against peripheral nerve epitopes. This is just these are myelin stains of nerve, and we ought to see black lines here. Instead, you see this sort of moth-eaten appearance, and this is following autoimmune attack on a nerve actually this was a patient with AIDP. CharcotMarieTooth Disease is a heterogeneous group of diseases of peripheral nerve. These are inherited motor and sensory polyneuropathies, and the clinical presentation we see, these people have very thin legs and high-arched feet and hammer-toe deformities. And the CMT world is very complicated. There are now 17 genes involved in various forms. The most common one, common mutation is for PMP22, causing Charcot-Marie-Tooth type 1A. So just to kind of give you the daunting number of genetic mutations. And before I get off of Charcot-Marie-Tooth disease, I would also mention that we still do not understand why patients with the very same genetic mutation have vastly different presentations of disease and vastly different severities of peripheral neuropathy. So for basic scientists that investigate Charcot-Marie-Tooth disease, kind of the next stage of investigation is probably going to focus on gene modifiers to explain why people in the same family with the same mutation are so vastly different. So on to the neuromuscular junction. This is my favorite area, so I will try not to be too biased about this. So on the presynaptic side, the Lambert-Eaton myasthenic syndrome is an immunological disease of the voltage-gated calcium channels at the presynaptic nerve terminals in nicotinic synapses. So as you probably remember, we have nicotinic synapses, cholinergic synapses in our autonomic ganglia. So these patients not only get weakness because of a neuromuscular junctional defect, but they also get dysautonomia. So they can have orthostatic hypotension, dry mouth, sexual dysfunction, constipation, and those sorts of symptoms. About half of the time, this is a paraneoplastic disease, usually associated with small cell carcinoma of the lung. And about the other half of the time, it's an autoimmune disease that's associated with other organ-specific autoimmunity. So we treat this disease either by treating the cancer or by using immune modulating agents. Botulism, which I'll talk about a little bit later, involves a lesion of one of the proteins that brings the acetylcholine vesicles down for docking and release into the synaptic cleft. Congenital myasthenic syndromes are exceptionally rare. These are inherited structural disorders of the neuromuscular junction. We have both presynaptic and postsynaptic varieties. The most common neuromuscular junctional disorder is autoimmune acquired myasthenia gravis. We've had thanks to Don Sanders' interest in myasthenia gravis, we have one of the probably world's largest myasthenia gravis clinics here at Duke. Many of these patients have acetylcholine receptor binding antibodies, but about 8 years ago, we found muscle-specific tyrosine kinase antibodies in a number of our seronegative, that is acetylcholine receptor binding antibody negative patients. The pathophysiology of MuSK myasthenia may be different. MuSK, without getting into it too deeply, MuSK facilitates the aggregation of those acetylcholine receptors at the postsynaptic membrane. So they're all in one place to receive the acetylcholine. So if you knock out mice so that they don't have MuSK, they're stillborn, they're arthrograpotic because they apparently don't have appropriate neuromuscular transmission. So MuSK is important. And then we still have this group of seronegative patients, which suggests that there are other epitopes that we're not aware of that we're going to learn about. Organophosphate intoxication isn't a large source of junctional disease in this country, but it is in some other countries where pesticide use is not quite as regulated. All right, motor neuron diseases, the most common of which is ALS. So everybody's aware of Lou Gehrig's story. He contracted ALS in his early 30s and died. And in this country, it's known as Lou Gehrig's disease. In ALS, there's disease both of the anterior horn cell or lower motor neuron and of the upper motor neuron as well. And I don't know if this imaged very well, but here's another spinal cord section. Here we have the dorsal side and the ventral side, and we've got our posterior columns with sensory information staining normally, but our anterior horn is not staining normally, nor is the corticospinal tract. Our spinothalamic pathways for sensation are staining normally. So hence it's amyotrophic, loss of muscle mass, lateral for lateral or corticospinal tracts being diseased, so amyotrophic lateral sclerosis. There are variants of ALS in which there's only upper or lower motor neuron disease. Those are fairly rare, as well as a single limb version of motor neuron disease that has a more benign course than ALS does. 40% of patients with ALS are alive 5 years after their initial symptoms. So this is not, this is not something one wants to have. It has a miserable prognosis, and I'll talk a little about some of the trials that are going on in ALS. Problem with ALS is we still don't understand the pathophysiology of ALS. We do not understand why the anterior horn cells and the corticospinal and corticobulbar fibers just up and die. And I have a feeling unless we serendipitously happen upon the right agent, we've got a ways to go. Inherited motor neuron disorders, most common is something called spinal muscular atrophy. Wernicke-Hoffmann disease is something that some of you may have heard of. This is a form of spinal muscular atrophy that's fatal before the second birthday. Intermediate and juvenile forms of muscular atrophy have much more longevity, and this involves a lesion of something called the survival motor neuron gene. Kennedy's disease, which is named for William Kennedy at the University of Minnesota, not the other Kennedys, is an X-linked recessive disease. So only men get this. And this involves denervation of the bulbar muscles, in other words, the cranial muscle or the muscles innervated by the brainstem. Okay, so these patients get slurred speech, difficulty swallowing, tongues that become shrunken and atrophied. I tell our fellows it looks like this. It looks like a Shar-Pei because it's all wrinkled. And there's a close association with the gene for the androgen receptor. So many of these men have gynecomastia. So this is a kind of relatively rare form of inherited inherited motor neuron disease. And then finally, familial ALS comprises about 10% of the total patients we see with ALS. Okay, myopathy. So we have autoimmune myopathies, which are most common varieties, poly and dermatomyositis, something called necrotizing myopathy, and finally sarcoidosis. That's probably the largest portion of what we're seeing for myopathy. And over here is a good example of how histopathology can be very helpful to you. This is a slide of a patient with dermatomyositis showing the characteristic finding of perifascicular atrophy. So I don't know if you can tell from where you're sitting, but the muscle fibers, which are seen in cross-section here, are much smaller at the edge of this fascicle than they are in the middle of it. I don't think I would have to twist your arm too much to convince you of that. And the other, even though you can't see it all that clearly, there are more purple inflammatory cells than there ought to be in this section. All right, inclusion body myositis in some of our older texts was listed under inflammatory neuropathy or myopathy. And this was a disease that was totally unrecognized until the early 1980s. And we see muscle inflammation in inclusion body myositis, but we think that it may be secondary. This disease has failed to respond to all kinds of attempts for immune modulation, IVIG infusions, corticosteroids, and other agents. It just doesn't respond well to immune modulation. So we don't understand the pathophysiology of inclusion body myositis, and yet it is probably the most common late adult onset myopathy. It doesn't shorten life, but it makes life much less convenient. Because of the distribution of muscles involved, most of these patients will ultimately become wheelchair bound. It has a predilection for the anterior thigh or quadriceps femoris muscles and the deep finger flexors. And this is actually an easy one for us to pick up in the clinic because of the distribution of findings. If we understood what caused that, I think there would be a lot of interest in developing treatment for this. And with people living longer in general, I think we're bound to see quite a bit more of this than we've had in the past. Okay, toxic myopathy is an important category to go over. With the widespread use of cholesterol-lowering agents, we're seeing more and more patients that have cholesterol-lowering agent myopathies and have to either switch to an alternative cholesterol-lowering agent or stop them altogether. Critical illness myopathy in the ICU setting is a major issue. This was originally recognized in patients with status asthmaticus that would receive high doses of steroids for reactive airways disease and simultaneously receive non-depolarizing neuromuscular blocking agents so they could be effectively ventilated without barotrauma. The combination of these two things causes a myopathy in which those thick myosin filaments drop out. So sometimes the muscle histopathology can be fairly specific. This can also be caused by high doses of corticosteroids in generally immobilized patients. The Europeans tend to use propofol instead of non-depolarizing neuromuscular blocking agents, and their patients get the same sort of myopathy. So there's something about immobilized muscle. There's actually an animal model for something that's very close to this. But this is probably a significant public health issue as well, because even though the prognosis is good from this, provided you live from whatever brought you to the ICU, the amount of rehabilitation and lost work is not insignificant. There's an entity called critical illness neuropathy also that I didn't mention. We don't understand the pathophysiology of the critical illness neuropathy, and Chris Cox in pulmonary is very interested in this, and the prognosis from it may not be as favorable as it is from the myopathy version.
Vern, I had a question about what is the occurrence of this myopathy and cholesterol-lowering agents in people? How prevalent is it?
It's hard to know because I'm not aware of any population studies that have been done with this. When the cholesterol-lowering agents were being introduced to the market, and my source would be John Guyton, because we had him come to neurology grand rounds and speak. A very high CK level was permitted. That was how myopathy was screened for. I forgot, it was a 5-fold elevation, or it was something very substantial. I might not have been that liberal with how I screened for myopathy, but that's how it was done in these studies. So I don't think we have a good idea about how many people are getting this. Unfortunately, it doesn't have a unique, this is another one of these diseases that, although it's prevalent, there are no unique findings. I mean, there's not a muscle biopsy finding to say, you had, this is your cholesterol-lowering agents that's causing your muscle disease. So it's problematic, and if you were going to study it or do some sort of clinical trial with it, it would be hard because our methods of diagnosing it are rather antiquated. I would make the same statement about critical illness myopathy. This may be happening much more than we realize. Patients who have been in the intensive care unit, we usually cut them a break for being weak and deconditioned. How many of those weak, deconditioned people actually have some of this is uncertain. And until we come up with a better biological marker for this or some sort of diagnosing criteria for this, I don't think we'll ever have a good handle on its frequency. So that's one of the things I wanted to convey in this talk is some of these are, even though they're relatively common, they're hard, they can be difficult things to diagnose.
So the interesting question to me then is, when you have the advertisements on television, if you experience muscle weakness with Lipitor, go see your doctor.
Exclamation point.
Right. In your criteria, your laboratory criteria is, CK of 500.
So So in the trials, my understanding is that it was a 5-fold elevation.
Five-fold.
So if you assumed upper limit of normal would be 250,
Right.
you know, you'd have to have a CK over 1,000. I think that is probably a little on the liberal side.
Right, and then you'd have to be crawling into your physician, you know, and presenting, you know, crawling in. So, I mean, seriously, this is a very important, you know, health issue impact, because we're being told continuously, you know, that everybody, well, some people think everybody should be on Lipitor, or everybody should be on cholesterol-lowering agents.
Yeah, many of these patients will have muscle pain. And one of the clinical problems that I run into is when patients have muscle pain or myalgias and they don't have elevated CK, and it started while they were on one of these agents. And then the issue is their muscle pain related or independent of it? And that can be a very hard question, because even, you know, stopping the cholesterol-lowering agents doesn't always relieve the muscle pain. And then we're left holding our hands up, not being able to understand why the muscle pain is there. So most of the patients who have cholesterol-lowering agent myopathies that come to attention usually come because of muscle pain, or their physician is screening the CK level and observes an elevation and either sends them to a specialist or stops the drug or changes to another one. So some physicians are very keen to pick this up, and others aren't.
So my follow-up question then is, what's muscle pain? What's the distinction between muscle pain and a muscle ache? And, you know, if you've worked out, you know, and maybe strained something, you know, I have muscle pains all the time.
Right. No, and that can be hard. The patient on cholesterol-lowering agents that I would be most concerned about would be a patient that had a widespread distribution of muscle aching and no really good explanation. You know, they did the triathlon in, you know, Wilmington last weekend or something like that. Somebody who doesn't really have a situational explanation, and they've got a fairly widespread distribution of muscle pain. Those would be the ones. And if the CK were elevated on top of that, that would very much raise your suspicion for this. But I think, you know, it is one of the hard things is that we don't have, there are some diagnostic criteria for this, but we don't have a good biological marker for this. So for, you know, all the millions of people that are on cholesterol-lowering agents, the primary physicians who are prescribing those cholesterol-lowering agents, other than following the level of muscle enzyme in the blood, don't really have a good way to detect them. So that's going to be an area for improvement in the future, hopefully. How many folks are on these and the widespread problem with hyperlipidemia in our population. Yeah?
I'm sorry. So the conditions that's associated with taking the cholesterol-lowering medications, is that reversible once you come off the medications, or is that continuous?
So it's not absolutely clear. So some patients do better and some patients don't, and there's also the issue of other medications that compete for the same mechanisms of hepatic metabolism. So for example, a patient on both a cholesterol-lowering agent and cyclosporin, we see a certain number of cases of rhabdomyolysis because they both compete with the same liver enzymes for metabolism. So your question is it always reversible? I don't know enough to tell you for sure. It's usually reversible in my own experience, but I don't want to sell myself as an expert in this particular issue.
Should a patient on a cholesterol-lowering agent get tested every year for CK elevation?
No, that's a good question, and I don't really know the answer. I guess what I would propose would, if I were an internist prescribing a cholesterol-lowering agent, I personally, and because of my current biases, would get a baseline CK, check CK in a month after treatment, or if the patient developed myalgias or any sort of symptoms suggesting weakness. But I'm very biased, and that may not be a cost-effective way to practice.
Mm-hmm. Thank you.
Okay. So inherited myopathies include muscular dystrophies. So these are inherited and progressive diseases of muscle. Congenital myopathies are conceived of as being inherited but not progressive, or minimally progressive. And congenital myopathies also have unique muscle histopathological findings. In reality, the distinction between these two is not all that great. They are all inherited. Some of the muscular dystrophies aren't that progressive, and some of the congenital myopathies are fairly progressive. So the nomenclature is changing. We also have some metabolic myopathies in which there are abnormalities of energy metabolism, such as mitochondrial disorders, or involving energy metabolism problems that result in accumulation of storage products, such as glycogen storage disorders or Pompe disease, and I'll talk about that in a minute. And this is a Gamori trichrome stain of the ragged red fiber. Okay, this represents the subsarcolemmal accumulation of mitochondria, and this is the finding that one wants to see when they're looking for a mitochondrial myopathy. Now, this doesn't tell you where the mitochondrial problem, if it's a somatic mutation or a mitochondrial genome mutation, but it does tell you you've got a mitochondrial myopathy. So the nomenclature in inherited muscle disease is changing. And it's changing because we recognize gene location and gene product abnormalities now, rather than relying on the clinical presentation. And so we really conceive of Duchenne and Becker muscular dystrophy as dystrophinopathies. Limb-girdle dystrophies, so this whole set of limb-girdle dystrophies that are called severe childhood onset autosomal recessive muscular dystrophies all involve mutations in sarcoglycans, alpha, beta, and gamma. Limb-girdle muscular dystrophies, for example, limb-girdle muscular dystrophy 2A, which is the most common autosomal recessive, involves mutations in calpain 3. Tibial muscular dystrophy in a gene called titin. This is what we call a distal myopathy. So again, the nomenclature is changing because we're finding out what the gene products are. So we may call this, instead of a distal myopathy, we may call this a titinopathy one day. So so this is just an illustration of, as we've gotten wiser to molecular genetics and gene products, we've found out that there are a number of different types of limb-girdle muscular dystrophy. So remember how I mentioned the exam is not too different. The EMG is not too different. The muscle histopathology, unless you're staining for the particular protein, is not too different. And so these are in large part defined by molecular genetics. This is the most current cartoon of muscle. And remember, I was referring to the connection between the sarcolemma and the contractile portions of the muscle. And many of the proteins involved in inherited muscular dystrophies involve problem in a protein involved in this connection. So our here we have our dystroglycan, sarcoglycan, dystrophin here in blue, titin, and down here is our contractile portion of the muscle. So sarcolemmal membrane, contractile portion, and we've got all these proteins that connect the two. And when they're not formed correctly or when they're absent, we get a muscle disease. So I'm not going to get into great details, but dystrophin, sarcoglycan, myrosin, caveolin, calpain, etc. So many of these things were totally unknown when I started my training, and now the whole field has changed. But because, and important for this group, because we're recognizing where the abnormal proteins are, we're going to be poised to do something about it. And I think that's why this sort of knowledge is becoming important. But things have changed quite a bit since I did my training. So let me just touch on a few disease examples here. Dystrophinopathies, we've got gene therapies in development and trials, and I'll talk a little more about that. For Pompe disease, thanks to Y.T. Chen and Priya Krishnani's work here at Duke, there's an enzyme replacement therapy to replace the missing enzyme that results in the buildup of glycogen in muscle tissue and liver, which is a great advance, but it's very costly. For a 70-kilogram person, it's probably $300,000 a year for treatment. How to pay for that treatment is an issue. So, in Guillain-Barré syndrome, we've had great successes with plasma exchange. Back in 1985, the North American Plasma Exchange trial demonstrated that the time to recovery was improved. IVIG was established to be effective during the 90s and in a trial that was not done here in the United States in 1997 because we already had something that worked, and ethically we couldn't compare it with something else. And that remains a problem, I guess, in all of these diseases for which we have treatments that are fairly effective. The ethics of testing other treatments that might be more effective is somewhat problematic, and this group is probably well aware of that. Myasthenia gravis, we have effective agents, but again, we're trying to develop more effective treatments. I'll talk about a couple of the important trials there. Botulism is sort of a contemporary issue thanks to the prospect of world bioterrorism. We really have some problems with how we diagnose botulism, and because it is a disease that is progressive and will cause ventilatory failure, it's important that we have more expeditious ways to make the diagnosis. And finally, in ALS, we don't have a biomarker for the disease. We are at a very rudimentary point in understanding its pathophysiology, and that creates a problem for developing rational therapies. So this is this panel up here shows Gower's signs. So as patients with Duchenne dystrophy develop limb girdle weakness, they have to stand by forming a tripod and then pushing their trunk up using their arms in this fashion. And so those clinicians training in neurology recognize this as Gower's sign, and this was the big thing you looked for to diagnosing Duchenne dystrophy. We're paying a little bit more attention to dystrophin mutations now because we can get them. This is a fairly common disorder. It affects 1 in 3,500 boys, so this is a significant public health issue. It's early onset. The CK is very elevated. Okay, so this is a good screening test for this particular disease. Pediatricians are aware of this, and most of the patients that get referred to us have had a CK, and it is very elevated. And these people these kids have a genetic lesion such that they don't make dystrophin. There's a milder form of dystrophinopathy called Becker muscular dystrophy that's later onset, slower progression, and they have a reduced or abnormal, they produce less or an abnormal dystrophin protein. Okay, I'm going to skip this for the sake of time. The question about, gosh, is the cost of doing molecular genetic studies relevant? In the case of Duchenne dystrophy, it is. Most of these kids have large deletions. A few of these kids have premature stop codons. We're very interested in those because we have some agents that we have an agent in a clinical trial that we can, that will allow read-through of that and the potential for these kids making a more normal dystrophin protein. And there's some other mutations that are relatively uncommon for which we may have treatments available. So right now, Stephanie Wexler is the PI for PTC 124 trial, and we have, I think, 3 or 4 kids enrolled in this, and we're hoping for some success with them. Patients with about 10% of patients have small mutations in dystrophin that may be treatable with antisense oligonucleotides by binding to the abnormal area of the gene so that we don't translate that abnormal part of the dystrophin protein. So this would have to be, we absolutely would have to know about the molecular lesion in these patients, and such an antisense oligonucleotide would need to be custom synthesized for these particular patients. Now, most patients have large deletions, and this is a problem because the amount of dystrophin is your biggest gene in the body, and so the amount of missing DNA is very significant, and the viral vectors that are available are not big enough to carry all the missing DNA into the muscle cell. So work is currently focusing on making mini dystrophin genes, what we think are the most important parts, to move those into the myocytes to see if maybe that will allow us to synthesize a more normal protein and arrest this progression of disease that renders most of these boys dead of respiratory failure in their early 20s. Okay. Talked a little about Pompe disease. I'm going to skip GBS. Talk a little about myasthenia gravis. So many of these patients will have fluctuating, fatigable weakness of the eye muscles. They'll get binocular double vision, have eyelid drooping, and 3/4 of these patients will develop oropharyngeal weakness or generalized weakness within the first 1 to 2 years. And if they're not treated, they can develop a problem called myasthenic crisis where they have to go on mechanical ventilation. So recognizing this is important. And I like, Dr. Grobe has studied natural history of myasthenia for some years, and this is one of my favorite graphs that kind of shows where we've been and where we're at now. So the open points here show various treatment advances through the years. So in the 1920s, tracheostomy, endotracheal intubation, neostigmine was introduced in the late 1930s, antibiotics in the late 30s and early 40s, positive pressure ventilation in the early 60s. In the late 60s, we started using immune modulation in these patients. It was then understood that myasthenia gravis is an autoimmune disease, and that understanding allowed this last little drop-off in terms of mortality. So we're actually now in 2009 down somewhere around 2%. So we've come a long way, and this is something we can all be proud of. And then the prevalence, because these people now live, is going up, and we're proud of that too. All right. So clinical trials in myasthenia gravis. The most recent trial that concluded was one in an agent called mycophenolate mofetil that was originally developed to prevent rejection of renal transplants. It represented a significant advancement from cyclosporin, which was nephrotoxic. There was funding from FDA Orphan Products Development, and the original study design conceived of comparing CellCept to placebo, but that was not thought to be ethical, give any treatment at all. So the comparison was to low-dose prednisone. Well, make a long story short, low-dose prednisone is a lot better medicine than we give it credit. Yes, there are a lot of side effects with it, but the 3-month outcome showed that both our placebo, 20 milligrams a day of prednisone, and our CellCept patients improved, but there was no significant difference between the groups. There's been a lot of retrospective discussion about how the trial could have been better designed. There's probably no way we could have done a real placebo trial. One thing that could have been looked at would have been a longer experience and to see if CellCept would have been better in the long run. For patients that are diabetic, and that comprises more than half of our population of myasthenics, taking this much prednisone is a problem. So CellCept is a good alternative, but unfortunately the design of that trial did not prevent the demonstration of this. There's an agent called monarsen that prevents or that reduces the synthesis of acetylcholinesterase, so that acetylcholine stays in the synaptic cleft longer and patients may be stronger. Doesn't do anything to the autoimmune attack on the membrane. Rituximab, which inhibits B cell function and the formation of the antibodies that attack the muscle membrane, is also a promising therapy. And complement inhibitors are also being tried for patients with refractory myasthenia gravis. I'm going to just skip through some of these. I guess I'll talk about botulism a little bit. So there's been contemporary interest in bioterrorism because of the potential to weaponize botulinum toxin, namely through an aerosolized form. A laboratory accident in Germany in the early 1960s represented the only documented cases of inhalational botulism. The Amschanrikio cult attempted to release aerosolized toxin on several occasions, but they failed to succeed, and as is well known, the Iraqis had quite a bit of weaponized toxin that was never used. We're told to suspect bioterrorism use of toxin if we have an outbreak with numerous cases, types of toxin that don't normally cause human disease, a common geographic factor without a common dietary exposure, Aunt Susie's potato salad with the rancid mayonnaise, and multiple simultaneous outbreaks. And this is a well-known case in the news back in November of 2004 of iatrogenic botulism. This particular physician who had lost his license and ran the laser hair removal clinic injected this fellow and his wife and himself and his wife with toxin that was research grade that he obtained from a laboratory in New Mexico for less than it would cost to buy the pharmaceutical grade toxin, and they all spent at least a month on ventilators. There's a write-up on this in JAMA. If you want an interesting read, get the article. It is really something else. So, and getting back here. So my criticism with where we're at with botulism is this: the mouse bioassay is very resource intensive and it's very slow, so that by the time the mice get injected with the serum from the patient, the stool extract from the patient, the food stuff that was thought to be contaminated. It takes 48 hours to get a result. So to get those people in the hospital, get their samples set off, I mean, that's another 24 hours or so. So you're talking 72 hours to get a diagnosis. Now, we do electrodiagnostic studies and we do other things and suspect this, but this is a problem. And the consequences are, if you get enough people coming down with botulism and it gets bad enough, they all need to be on ventilators. We run out of ventilators pretty easily. The treatment for botulism is to give an antitoxin, and the antitoxin is derived from equine sources, so literally horse serum. So that's a problem too, because most people have an allergy to horse serum, and you only get one time to give that, and then a person is sensitized to it. You do, and yeah, you can and do, and when the CDC sends you the anti-serum, it comes with a little desensitizing kit. We had a case last year. We actually used that. For infant botulism, the California Department of Health has human-derived immunoglobulin for type A and B, but you've got to send them a certified payment of, I think it's $64,000 before they will send you the anti-serum. So they want their money. So okay, and again, the antitoxin only works if you bind up the circulating toxin. So once the toxin binds to your motor nerve terminals, it's too late. So that's why a quicker diagnosis is important. All right, I think we're close to the end here. Last, I want to close with probably our most challenging disease, and that is ALS.
Dr. Jewell,
Yeah.
sorry.
Oh yeah.
Is there any benefit to plasmapheresis or anything like that with folks with botulism?
Not with botulism, because the protein would not be expected to be completely removed with plasmapheresis, and once it binds to the motor nerve terminals, it's there. So neuromuscular transmission is shut down, and usually by the time we see these patients, they're fairly far in. In an outbreak,
are there treatments that, are there treatments where you can, are they looking in research for this or other things, where you can unbind something where it has an interest in being bound more tightly to something else? Like, can you force unbinding? That's
a good question. So I don't know of anybody that's actually an interesting thought. To give something with greater affinity, that's actually a great thought. You should do something with that. Because once those snare proteins I showed you earlier on, once those are cleaved, that kind of the game's over. So the thing would be your suggestion to give some snare protein-like maybe substance to try to get the toxin to, and then freeze them. There are binding sites on, they bind to specific sites on the motor nerve terminals, and I guess if you were able to synthesize a compound with that, or else do some sort of pheresis and run the serum through a column that had that bound to it, and kind of try to pull off all the toxin, that would be another idea. That's a good idea. All right, so ALS is challenging, and for a whole lot of reasons. We don't understand the pathophysiology. By the time a person has muscle weakness, they've lost 50% of their motor neurons. So by the time a person becomes aware and the physicians become aware, half the battle is over. I mean, we've already lost half of the motor neurons. And there's no known biological marker, but there's a lot of work right now in attempting to find one, and that would probably be the biggest step forward we could make right now. Riluzole, is FDA approved for use in ALS. It slows progression a little bit. It's a glutamic acid inhibitor. It worked very well in animal models of ALS, not so well in humans. So longevity is extended by 3 months. Strength is not clearly better in these patients. It's a rational treatment to use, but I tell patients to be very tempered about their expectations. Good nutrition and positive pressure ventilation to prevent microatelectasis probably do more than riluzole does to prolong life. And I advocate these things because not necessarily they prolong life, they don't confer immortality, but they make the quality of life better. Unlike many patients with cancer who lose appetite, patients with ALS have appetite. If they can't swallow, they run around hungry. Having enteral access to give medicine is also important. So I think of nutrition and PEG as quality of life issues in these patients and not as life-sustaining issues. And that's an important distinction when you get into hospice sorts of issues. Same thing with positive pressure ventilation. This is BiPAP at night. So this prevents morning headaches and allows people to get a more restful night's sleep. And again, this won't confer immortality, but it just improves quality of life. It does extend life, absolutely. Many negative trials in ALS, cilio neurotrophic factor, brain-derived neurotrophic factor, unfortunately, creatine, minocycline. Here's a list of the agents currently in clinical trials. We're hopeful, but nothing just yet. So hopefully you know what neuromuscular disorders are. We talked about some of the diagnostic tools and their limitations, the need for timely, accurate diagnosis, and some diseases in which we have good treatments, we'd like to get better treatments, and some diseases we are really just starting the race in terms of finding a treatment. So thanks very much, and I'll take your questions.
Sorry.
Yeah.
Another question. You haven't talked, for some of the specifics, you've talked about some causes, but it seems like a lot of the causes are idiopathic. If they looked at infectious causes, environmental causes, because a lot of these diseases like ALS happen relatively late in your.
There's been a tremendous amount of interest in all kinds of environmental issues with ALS, and we've, so the one that I think has gotten the most press is that servicemen in the Gulf War and in Iraq, in the current Iraq War, are getting ALS at a higher rate than the rest of the population. And the reason for that is not entirely understood. There's been a lot of speculation about the use of peritostigmine during the first Gulf War, which was done to try to offset some of the effects of some of the neuromuscular blocking agents that the Iraqis were thought to be ready to utilize. Although I can tell you we have hundreds of patients who receive peritostigmine for myasthenia gravis and have been doing it for years that don't have that. Trauma has also been a question. No infectious etiology has been found. There are certainly examples of motor neuron diseases in which are viral. Polio, West Nile virus. So a subset of West Nile virus causes poliomyelitis. Polio meaning gray matter inflammation. So the flaviviruses, so Japanese equine encephalitis, West Nile virus, these all can cause a poliomyelitis. So that's never been recognized in ALS. I don't think you could, it's still a possibility until we come up with a better explanation. All right, thanks very much.